So infertility is defined as the inability to conceive despite engaging in unprotected sexual activity for at least 12 months. So there can be issues regarding female infertility and male infertility. So female infertility, we'll talk about female infertility first. So there's an issue with females having infertility issues if they're greater than 35 years old. If they have an endocrine disorder, which would mean that they would have abnormal body fat and abnormal hair distribution. If they've had any kind of surgeries in their pelvic area or abdominal surgeries, maybe that can lead to fertility issues. Gynecological surgery, abnormal pap smears, abnormal shape in uterus size. Occupational environmental exposures, if they're exposed to hazardous materials at work, that can lead to issues with infertility. If they're under or overweight, and if they smoke or use drugs. For men, if they have a medical history of acquiring mumps after their adolescent years, if they have endocrine disorders or any genetic disorders, it can lead to infertility issues. You want to go ahead and assess their sexual history, if they've had a history of STIs, if they have an issue with substance abuse, like using alcohol, drugs, tobacco. If they have exposure to teratogenic materials, and if their scrotum is exposed to high temperatures. We need to talk about this word. This is a teratogen. A teratogen, I'm not sure if I covered it, I can't remember, but a teratogen are things that can cause detrimental harm to the developing fetus. So diagnosing infertility in females, you can do a pelvic exam to assess for any kind of anomalies. They will do a hormone analysis. They'll do a post-coital test and a technique in mucus secretions. They will do an ultrasound to look at the organs. They'll do a hysterosalpingography, which they're going to put tubes into the fallopian tubes to make sure that they're patent. A hysteroscopy will be looking at the uterus, and a laparoscopy is done through the abdomen and looks at internal organs. For men, the first thing they're going to do is a semen analysis. Literature says that 40% a causative issue for infertility is because there's an issue with the semen. It's less invasive than female fertility screening, so typically we're going to start with this. Then they can do an ultrasound to visualize the testes and the scrotum. So what can we do to combat infertility? You can take medications to stimulate your ovaries to produce eggs. Things like Clomid, that's what this is. There's a high risk of having multiples in your pregnancy if you do get pregnant. There's things that your healthcare provider or the specialist can do to increase the chance of getting pregnant. They can do intrauterine insemination, or IUI, which is when the sperm is placed into the uterus at the time of ovulation. They can do in vitro embryo transfer, which means they fertilize the eggs in the lab and then transfer to the uterus. They can do gamete intrafallopian transfer, where the oocyte is retrieved anyway, placed with a motile sperm and then placed in the tubes. You can use a donor oocyte, which we use donated eggs that are inseminated and placed in the recipient's uterine. The recipient does undergo hormone therapy to help prep the uterus. They take, progesterone and those kinds of things. A donor embryo, which is embryo adoption, when we have donated embryos that are placed in a recipient's uterus. That recipient as well, just like the one above, undergoes hormonal therapy to kind of prep that uterus for implantation. A gestational carrier or an embryo host, in vitro fertilization is done, and the embryo is placed in another person to carry the pregnancy. This is actually a contracted arrangement. It's done through a lawyer, and the carrier has no genetic investment with the embryo. A surrogate mother is a person who is inseminated with semen and carries the fetus until birth. And a therapeutic donor insemination is when donor sperm is used to inseminate a person. So some nursing education about infertility. We need to recognize that infertility can be a stressor to a relationship and put a stressor on that couple. We give them an abundance amount of education to help assist with their decision making. We talk to them about the use of reproductive medications and how those medications can increase the chance of a multiple birth by 25%. And we give them referrals to grief and support groups when they can't get pregnant. The final piece of this, we're going to talk about fetal development. Here's the word teratogen again. We talked about that earlier. So any drugs, viruses, infections, or other exposures that can cause embryonic fetal development is a teratogen. Birth defects can occur from genetic disorders or would be the result of the teratogen exposure. The degree or type of the malformation varies based on the length and the amount of exposure that happened and where they were at in their gestational age. So again, if we are in the first 8 weeks of pregnancy, there's a bigger impact the teratogen has on the developing embryo. After 13 weeks gestation, the exposure to teratogens may cause fetal growth restriction and reduction in the organ size. The majority of the birth defects occur between 2 and 8 weeks gestation. Think about that. Somebody who's 2 weeks pregnant, they don't know they're pregnant. And if you read this, the majority of birth defects happen then. That's kind of scary, so we just need to be aware. The earlier the fetus or the embryo in this case is exposed to the teratogen, the higher risk there is for damage. So here are just some pictures because I think pictures are fun. A 4-week embryo here. Here's a 7-week embryo. See the little eyes and the little hands. This is a 9-week-old fetus here. And then we've got 14 weeks and 20 weeks. In humans, each cell normally contains 23 pairs of chromosomes for a total of 46. 22 of these pairs are called autosomes, which means they look the same in both males and females. The 23rd pair, the sex chromosomes, differ between males and females. This slide discusses when there is an abnormality in the chromosome disorder, a chromosome number. Abnormalities of chromosome number are most commonly seen as trisomies, monosomies, and mosaicism. So Down syndrome, which is trisomy 21, is the most common chromosomal condition. And when somebody has Down syndrome, there's an extra copy of chromosome 21, which is why it's called trisomy 21. An infant with Down syndrome may have low set ears, a protruding tongue, and a simian crease in the palm of the hand. The simian crease is the line, kind of goes directly across the palm of the hand. Trisomy 18 and 13, both of these have very poor outcomes. Over 70% of these babies die within the first 3 months of life. Monosomies, an individual with monosomy has only 45 chromosomes, and this is incompatible with life. And mosaicism is common in Down syndrome. Our final slide talks about twins. The left-hand side talks about fraternal twins, and the right-hand side talks about identical twins. Current trends show an increase in twin pregnancies due to delayed childbearing and an increased use of artificial reproductive treatments. Fraternal treatments, they're called dizygotic. They're not identical twins. They have 2 of everything. They have 2 ovum, 2 blastocysts, 2 sperm, 2 amnions and chorions, and 2 separate implantations there. They're separate placentas. Fraternal twins are typically genetically linked, and certain ethnic groups have a higher chance of conceiving fraternal twins. Identical twins, so those are called monozygotic. There's a single ovum and a single sperm. There's one blastocyst that splits into 2. So we have 2 amnions, but 1 chorion, so we have 1 site here. Single ovum, single sperm, 1 single placenta. Identical twins are the same sex.
Before you begin this lecture, what I'd like you to do is pause this recording, and I'd like you to go onto the internet or go onto YouTube, and I'd like you to search for a video by the Khan Academy called Meet the Placenta. I don't have a link in this video, but I believe that this video that I would like you to watch gives a great foundation of the importance of the circulation and how the fetus gets the nutrients from the placenta and the circulation there. So once you have watched that, it's not very long. It's like 9 minutes long. Once you watch that, I'd like you to come back, and then we'll then begin this lecture with me, so I don't have to. Okay, so let's go ahead and talk about what you've already just watched, which is the Khan Academy Meet the Placenta. So what you're seeing here, this is just a cross section. This came out of your book. So this is over here on the left, on my left here, is the uterus with the fetus, right? And that black circle signifies the cross section that we're going to talk about. And in the Meet the Placenta video that you just watched, what you're seeing here is pretty much what he just drew. It's just a different way to look at the same thing. In the video, he drew this side, right? We talked about the maternal versus the fetal side, and then the circulation and the blood that goes through the chorionic villi, which is here. So all of this was described in the video. This is just a different way for you to look at it. So now let's talk about the placenta. In our time together, we've talked about many abnormalities of the placenta. In our antepartum high risk lecture, we talked about all the different things that can go wrong when the placenta is developing and what the ramifications of abnormalities of your placenta can lead to. Today, we're talking about the normal, well-functioning placenta. And the pictures that I'm going to show you are pictures of just that, all right? So what we're going to talk about here is how important the placenta is. And why it's so important is because it's the way that metabolic and nutrient exchange happens between the fetus and your patient. That's the only way. Now, you already know the fetal blood and the maternal blood does not cross, right? The patient's blood and the fetus blood does not cross. But there's exchange of nutrients. And again, you've just watched that Khan Academy video and you've seen kind of how that works, okay? So the placenta actually begins to develop in the 3rd week of the embryonic development. So basically, wherever the embryo attaches to the uterine wall is where that placenta is going to start developing at, all right? So as we go through the weeks of the pregnancy, now remember, most of your patients are going to talk by months. I'm 3 months pregnant, I'm 5 months pregnant. We, as healthcare workers in this population, serving this population, we speak in weeks. So the placenta keeps to grow and expand over the uterus until about 20 weeks gestation. And at that point, and I remember a 20-week gestational age of a 20-week uterus is not that big. All right. So when we're at 20 weeks gestation, the placenta is pretty good size and it covers about half of the uterus. And then as the pregnancy continues, the placenta is going to become thicker. Think of like a really good, high quality mattress that you spend lots of money on. The placenta is going to become thicker to help support that growing fetus, but it does not get wider. It does not continue to expand. The expansion ceases at about 20 weeks gestation. Next, I want to talk about this section here. Now, in your book, there's going to be all kinds of conversations about different parts of the the fetal circulation. So until this baby is born, just until like you were born, the blood moved through the fetus differently until the cord is clamped. Once the baby is born and the umbilical cord is clamped, the pressure behind that umbilical clamp forces these shunts I'm going to talk to you about to close. And at that point, the circulation becomes what yours and my circulation is. So when the fetus is in the fetal stage, it's a little bit different than when it's its own living all by itself away from its parent stage. So there are three shunts here. And what these do, they basically direct blood away from the lungs. Now remember, you already know the first breath of air that your baby takes when it's born, right? When the baby comes out and it holds its breath and cries, That's the first breath of air. When that big breath air goes in, that's the first time that baby has ever had air in its lungs. But when the patient is pregnant, the lungs are working but not functioning using air. So we have to make sure we do get some blood into them, but not enough to where they can work as functional lungs. So there are 3 shunts that actually make this happen, all right? There's the ductus venosus, the ductus arteriosus, and the foramen ovale. I want you to understand kind of what these are and why they're important. And it says basically right here, right? Your ductus venosus, what that does, It has blood bypass the lungs and the liver. The ductus arteriosus allows the blood to enter into the descending aorta, which does at that point, it bypasses those lungs that we're not using to breathe air. And the foramen ovale, what that does is it allows blood to enter the left and right upper chambers of the heart, which in that respect will bypass the lungs. So again, we're trying to get the blood to the really, really important functioning organs and getting just enough blood to the lungs to where they're getting perfused. So when that baby does take its first breath of air, they're going to be able to be working. This bottom section here, I'm going to kind of draw my little line. There are two sides to a placenta. There's your fetal side, and then there's your client side. We'll start with this side here too. This is the client side of the placenta. All right. So you can tell they're different colored. This is the side here that's attached to the side of the uterus. This is where all these lobes we've kind of been talking about when you have, quote, retained pieces of the placenta. Part of what your responsibility as a student in this class is when your patient has a baby and delivers their placenta, I want you to get your gloves on and I want you to palpate this placenta and feel the lobes and make sure that they're all there. Assuming that the placenta has not sat in the delivery bucket for very long, it should be the same temperature as your patient. Now, if it sat there for a while and exposed to the air, it'll be colder, okay? A couple of things before I go on to the fetal side here. At the time of delivery, when you're assessing your placenta, I want you to look for infarcts in your placenta, and you know what an infarct is, right? So when you have an infarct in the placenta, oftentimes it's caused by things like hypertension in pregnancy, smoking, drug use, those kinds of things, and you might see some compromise on your strip, which would make sense, and you know how to read that by now. But what you're going to see on your placenta, it looks like teeny tiny grains of rice. So when you've got your gloves on and you're moving your fingertips over the top of this placenta, they're very small and they're white, but they're also kind of hard like an uncooked piece of rice. And that is the best way I can describe that, what an infarct looks like. So let's talk about here, the fetal side. So your fetal side is the opaque gray kind of color. And because again, this is side that's floating inside the amniotic sac, so it's floating in water. Somebody once upon a time named these, and again, in case you come across and need to know what it is, your client side is Dirty Duncan and your fetal side is Shiny Schultz. This slide is again pretty much a picture of the same thing we've talked about. It's already talked about in the Khan Academy video. This is the same thing, it's just a different image, right? So this is your fetal circulation inside of a human neonate, okay? So you can see where your ducts are here. Where am I? There you go. And then here, over here on this side here, is just a picture without the human part attached to it, with the picture here that shows you where these shunts are. So again, whatever image helps you understand it, please use. So this slide talks about the different signs of pregnancy. Let's talk first about presumptive signs of pregnancy. So presumptive are things that the patient feels that makes them stop and think, maybe I'm pregnant. Okay, so they may have an absence of their menses, which is amenorrhea. Okay, that doesn't always mean you're pregnant, but that might be one of the first things that they notice. They also can experience maybe some morning sickness, but just be aware that just because it's called morning sickness does not mean it only happens in the morning. It should just be called sickness because it just depends on the person when it happens in the morning versus any other time of the day. Quickening, you know what that is. Uterine enlargement, it depends on when they're figuring out that they might be pregnant, and then they're going to be tired. In your first and your third trimester, you experience the most fatigue. Typically in your second trimester is when you kind of get feeling more like yourself again. So what happens is the patient oftentimes will feel some of these signs and think, maybe I'm pregnant, and then they should make an appointment with their healthcare provider at that time. And so what they'll do is they'll go in and see their healthcare provider and say, I'm experiencing these things, which lead me to believe that I might be pregnant. And then the healthcare provider will do their own assessments. So these are probable signs of pregnancy, okay? Things that are only observed by the healthcare provider. Okay. And then the bottom section here are the things that are only diagnostic of the pregnancy. Only the pregnancy can explain them. An ultrasound. If you see the fetus, that's only explained by the pregnancy itself. When you can hear fetal heart tones, again, only explained by the pregnancy. And palpation of fetal movements, again, only explained by the pregnancy. So once the pregnancy is determined, it is in fact determined that this person is pregnant, they will begin their prenatal care. Okay, and I'm going to kind of cut this slide in half. Whoopsie, sorry, I crossed off that word. So I'm going to actually start with the bottom half here. So in the beginning of this content, I talked about, it was actually slide 3, when I talked about the placenta. And then I said by 20 weeks gestation, your placenta is, what I said about that. Now I want you to look here at this box. 20 weeks gestation, your uterus is barely at the umbilicus. So again, I want you to kind of keep that in mind when you're talking about gestational age and the placenta, right? So keeping in mind the size of the uterus. So back to this picture here, this can tell you as the patient or the nurse or whoever where the fundus would be based on the gestational age of pregnancy, okay? So your patient, assuming that they have a low-risk pregnancy, we already talked about high-risk pregnancy earlier. So somebody who has a low-risk pregnancy, ideally, in a perfect world, they begin seeing their healthcare provider within the first trimester. Okay. Now, sometimes they don't, and it can be for lots of reasons. It can be because of access. It can be because of insurance. It can be because they just didn't know. So assuming that they know and they have access to a healthcare provider and they have access to insurance, all these things that we're going to kind of talk about today as in our time together. Ideally, they begin seeing somebody in the first trimester, and then they're going to keep marching along through their pregnancy. And here I have outlined what you can expect. So like I said, this is a low-risk pregnancy. They are going to go ahead and see their healthcare provider once a month up until about the 28th week of pregnancy. And then we get past the 28th week of pregnancy, they're going to go every 2 weeks. And then as we get into our 37th week of pregnancy and beyond, they're going to go ahead and go more often. So this is something we should keep in mind. Where does our patient live? Does our patient have access to a vehicle? Do they have access to cars? Lots of things that we're going to talk about today that really impact the prenatal care of our patients. So it's really important. We're going to talk about biases and social determinants of health today. And I really want us to keep in mind that just because somebody is, quote, supposed to do something, and if they aren't doing what we think they're supposed to do, I caution you to curtail your judgment until you've spoken to the patient and figured out why. So for example, if they didn't receive any prenatal care, why? Is it because they didn't have a doctor close by, they have no vehicle, or they just didn't have any money? Figure out kind of where they're starting from. Okay, anywho, so let's talk about how we can verify somebody's pregnant. I went backwards, I'm sorry. So this here, the HCG, I think we've talked about this before in our time together. That stands for human chorionic gonadotropin, and that's almost like the pregnancy hormone, right? When somebody is pregnant, those levels start trending up. And blood tests and urine tests that detect for pregnancy, what they're detecting for, when you're doing a pregnancy test, you guys, what we're doing for is testing for this. All right. High levels of HCG. We've talked about these already in our time together. So you should not have hugely high levels of HCG, right? So you need to know what your normals are, and then what are your patients, and figure out what that means. Lower levels of HCG could indicate that the patient is losing their pregnancy. We need to keep in mind that some medications can cause us to have false readings. And anytime you're doing any kind of a home test, whether it's a home pregnancy test or a home ovulation test, anything that measures urine, you want to do your first morning's urine, because your first morning's urine is the most concentrated, and that's the recommendation for that. So as our pregnancy progresses, right, we're going to keep talking about this as our pregnancy progresses. But let's start with our first prenatal visit. So when we go, they're going to confirm that, yes, in fact, this person is pregnant. All right, so that's good. And then they're going to determine the EDC, which you already know how to do. And if you have forgotten, I want you to go back and look into that, okay? Because I've already taught you that. And a lot of this you're going to see is stuff that we've already kind of talked about. All right. So they're going to check fetal heart tones. Depending on the gestational age, they might do an ultrasound. Now, remember, the earlier the pregnancy, they're probably going to do a vaginal ultrasound. Okay. So we can expect that. It's important that we obtain a very complete medical history and review of our patient's system, all their body systems. We need to ask all the questions that people are embarrassed to ask. It's really important because your patient's growing another human being here. So the more we can ask, the better care we can provide them. It's really important for you as nurses coming into this profession to establish an area of trust with your patient. Wherever you are, whatever department you work in, if your patients trust you, they will engage with you and they will share their stories with you, and that enables you to be a better nurse. So whatever that means to you, establish trust with your patient, okay? Because you need them to tell you certain things, and if they don't trust you, they may not want to do that. Also, no matter where you work, I also want you to make sure you check yourself. Because if a patient believes, if a human being, I'm just going to say, if we as humans believe that other people are judging us, we're not going to share our story. When you're a nurse, and again, I've already kind of said this, when you're a nurse and you're talking to your patients, you need their story. You need to hear about them, because the more they tell you, the better nurse you're going to be. So again, figure out where you're starting at and to keep your own personal opinions in check, and also to develop a sense of safety and trust with your patients so you can become a really great nurse and help them out, okay? So we're going to obtain all of this medical history. Whoopsie, I had hit the wrong one here. Pardon me. And we're going to do a physical assessment, doing vital signs and weight. It is really common, and whenever somebody goes into the doctor for a pregnancy visit, they go into the doctor, they give them a urine sample, and they'll check their urine, check their urine for protein and ketones and glucose, all those things, right? Check for any kind of a UTI that might be forming. They're always going to get them on the scale, and they're always going to check fetal heart tones at a minimum. They'll probably do more than those things, but that's something that they always do. Now, remember, as a labor nurse, which is what your faculty here are, we do not, unless we work in the doctor's office setting, we don't take care of people at this stage in their pregnancy. So when they're going in to see their healthcare provider, all the documentation is being documented on the prenatal record. And that's what we use in the hospital setting to find out our patient's history as well. So everything that we're talking about right now is going to go on the prenatal record. And again, at this first prenatal visit, they're going to go ahead and make sure we have, quote, like a pregnancy panel, which is your type 1 Rh, your VDRL, your rubella, hepatitis. So we're going to make sure we have all of those. We're going to get a CBC, a hemoglobin and a hematocrit, for that specific time. Okay, so we know what they're starting their pregnancy at. Are they anemic right out of the gates, or is their hemoglobin normal? It was their hematocrit normal. So we're going to establish a baseline there. We're going to make sure that the patient is not behind on their pap smears and cervical screenings. If they are, they're going to go ahead and get that done in that first visit as well. So now as our pregnancy is progressing, we're going to go ahead and do different things. I already told you every time that we go see the doc or go to see our healthcare provider, they're going to be checking heart tones. They're going to be monitoring our weight. They're going to be doing a urine analysis and our vitals. We already kind of talked about that. When we get to a certain gestational age, if the person is Rh negative, they're going to be given their RhoGAM or their Rho-D injection. Now, it depends. If they're Rh positive, they don't need that. So that's why I put PR in there. We're going to go ahead and offer them genetic screening testings. And again, if you have forgotten what that is, please revisit that lecture, right? We've already talked about that. So as there's different things we're going to assess for at the different gestational ages of our visits. Measuring fundal height is something that we're going to talk about in the next slide. So I'm going to have us put a pin in that. And what to expect, we're going to talk about in our time together today too. You know what Leopold's is, so we talked about that already. Depending on the gestational age. Now, Leopold's you can't do on an 8-week gestational age of a pregnancy. So you're not going to be doing that until you get closer to term. But keeping in mind that that can be done as well. We also can be assisting with the pelvic measurements as well. So on the previous slide, it talked about measuring fundal height, and this is the image that goes with that. It's called the McDonald's method, in case you're wondering, and how we do is we're measuring in centimeters from the pubic bone here to the top of the fundus. Now, again, it's going to depend on gestational age, right? So what you're going to do is you're going to never lay your patient flat. We've kind of talked about that, but with a little wedge under their hip. You're going to turn your tape measure so centimeters are showing. You're going to have the 1 centimeter down here over the bladder, and you're going to drag the tape measure over the uterus and then stop when you're at the fundus. And the centimeters should correlate with the gestational age plus or minus 2 weeks. Plus or minus 2 weeks. What that means is that if I have a patient who is having an uncomplicated singleton pregnancy and she's 37 weeks pregnant, when I measure their abdomen, the abdomen should measure 37, 38, 39, or 37, 36, 35. And there shouldn't be any variance on that. All right? Measurements may yield other things. Well, let's kind of talk about that. Well, what does that mean? Well, there are certain things that might make the abdomen bigger. A couple of things I'm hoping are already coming to your mind, right? But a couple of them, well, what if we have multi-fetal pregnancies? Would that make our uterus bigger? Sure it would, because there's 2 or 3 or multiple humans in there. What if we had polyhydramnios? Would that make our uterus bigger? It absolutely would, right? So I want you to think about the things that might make your measurements off. They can be too small or they can be too big. Another test that's done is measuring the pelvis. All right. Now, this is not something that your labor nurses do. All of this information is done when the patient goes and sees their doctor, and everything that is done at every visit is put on the prenatal record. So as a labor nurse, I have access to that when they're in my department, but I personally in labor and delivery am not doing this test. Okay. So if you come across your patient, your labor nurse, and you have a question about this, they may look at you like they have no idea what you're talking about. And they probably don't, okay, because they don't do that. This is part of their job. Anywho, so in your textbook, there's about 14 different images that when you're looking at somebody's pelvis, and that's fine if you want to know what they are. But for today, the most important thing is this, the obstetric conjugate. That's what I'm going to talk about. The rest I'm not even going to talk about because look at them. They're all here. You can look them up if you want to know what they are. All right, so why does this matter so much? Well, it matters because the obstetric conjugate is the smallest portion of the pelvis which the fetus must go through. So it's important that the measurement is 10 centimeters or more, right? I want you to think about that. Now, stop a second. That should make perfect sense to you. You know that the cervix needs to be 10 centimeters before the baby can be delivered, right? And there's alignment there because you want the obstetric conjugate to be 10 centimeters or more. All right. When the obstetric conjugate measures 10 centimeters or more, it allows for the average size baby to pass through, which is about 7.5 to 8 pounds. Okay. All right. So let's just stop and have a conversation, right? So it could be that your patient's obstetric conjugate is measuring smaller than 10 centimeters and they're 8 weeks pregnant. What does that mean? Right now, we're just gathering information. What it might mean is when they get to be having their baby and they're in labor and they're pushing, they may have their pelvis might be too small to where the baby does not descend in station. Okay. And that could be, right? But we don't really know that that's going to happen because we don't know how big the baby's going to be because this is done very early on. But you will see that this is one of the tests that your healthcare providers do for your patient. So for the next few slides, we're going to talk about the physiologic changes of pregnancy, the things that you can expect that are normal. And again, we're just going to kind of talk about this together. So in our reproductive area, this is where all these changes are happening. A lot of stuff happens here, right? We're growing this human inside of our uterus. Our ovulation is going to stop. Our periods are going to stop. Our uterus is going to get bigger. All these things we've already talked about. the development of the mucus plug starts. And what that does is it kind of closes up that cervix as your patient gets closer to labor, and then they will pass that mucus plug. All right. We are growing another human being, so it would stand to reason that our cardiac output does go up and our blood volume does go up, right? Because not only are we supporting our body, we're supporting another body that's actually growing and forming. So we need to have that increased circulation to support another human being there. Now, look at the respiratory tract. And again, all these things, I'm sure as I'm saying them out loud, you're like, oh, yeah, that makes sense. And that's my hope for you. And if not, let's talk. Let's figure out how we can help this make sense for you. So, you've all seen somebody in the third trimester of pregnancy with that very big gravid uterus. So as that uterus gets bigger and bigger in that third trimester, the fundus is really pushing up against the diaphragm and pushing up against the bottoms of the lungs. And that can cause some shortness of breath. And that's to be expected in the third trimester, right? Because anatomically, there's compression of those organs. So that would make sense. The oxygen needs are going to increase. Again, we're growing another person. What do you think it takes for one human body to develop and grow another human body, right? And that's what we're talking about here. And our pelvic joints relax, again, getting us ready to go into labor and support the baby that's coming through the pelvis. This picture here, I'm going to switch my colors. I choose blue. This picture here describes the issue with something called vena cava syndrome. I didn't put it on its own slide just because we can just chat about it here. In your end of your second and throughout your third trimester, that uterus is real big, right? Inside that uterus, we've got the baby or the fetus and the amniotic fluid and the placenta, and it's heavy. If you lay your patient totally flat, which is what this picture is here, I don't think I can zoom in on it, but anyway, you get the idea. This gravid uterus, I don't want to draw on it. This gravid uterus here, what's happening is it's compressing your vena cava. You see that? Your vena cava runs in between the back of the uterus and the front of the spine. So when you lay a pregnant person flat, and I'm talking flat, not like on the little tilt. When you lay a pregnant person flat, it suppresses the vena cava, and it ineffectively cuts off the circulation to the top of half of their body. That's not good, right? And how do you know? Because your patient in the hospital is going to put the call out on that are going to say, I don't feel right. My ears are ringing. I feel dizzy. The fastest way to fix it is to put them on their side. And yes, you can get a set of vitals too, but by the time you can get a set of vitals, if you put them on their side, as soon as you move that pregnant uterus off of the vena cava, circulation comes right back and they feel better. So you will see when somebody is in their end of their second and throughout their third trimester of pregnancy, education should be not to lay flat, but even when you're in there in the hospital with us as the labor nurses, we either have them in a semi-Fowler's or a low Fowler's, right? Because then that's not flat. Or on their sides. Ideally, left lateral really kind of helps fusion to the fetus. When they're having a C-section, they're not flat on the table either. We're going to put either tilt the table itself, or you can even just get like a blanket. It doesn't have to be a huge thing, just enough to get a little bit of a tilt in the pelvis, and that will decrease the pressure on the vena cava, and you won't have any issues there. This slide here just talks about the increasing lordosis that happens as pregnancy progresses, and why when somebody has had a baby, regardless whether it's a C-section or a vaginal delivery, regardless if they've had an epidural or not, their back hurts. Well, that would make sense, right? So here, the bottom of my slide got cut off, so I'm going to write it. So this is a 12-week pregnancy, so we don't have much curvature here. Again, depending on the anatomy, if they have predisposing back problems, this is going to be a little different. Your second image is 20 weeks. So we can see our curvature getting a little more profound. Then we've got 28 weeks here, and we've got 36 weeks, and this is 40. All right, just a visual for you. More changes that will happen during the pregnancy is because we are pregnant and we're releasing the HCG hormones, right? We've talked about that already. So when this is in your system, it can cause nausea and vomiting, all right? So that's what explains that. You can have some issues with your kidneys because of our progesterone and issues like there. And then these are the hormones that our placenta is producing. and we've talked about these throughout all of our time together, they have a really big job. They are going to help us maintain the pregnancy. For example, I already talked about HCG. I want to talk about estrogen and progesterone before I go to prostaglandins. So, with estrogen, let's talk about progesterone first. So, let's talk about early on in our pregnancy. We are trying to maintain the pregnancy, right? So, our body is producing a lot of progesterone to maintain that pregnancy, and our estrogen levels are lower. Okay. And then as we're plugging along through our pregnancy, our progesterone is still kind of dominant. Once we get closer to get to our due date, those hormones are going to flip. Our progesterone level is going to go down, our estrogen levels are going to go up, and that allows our body to start having the contractions. So I want you to think about estrogen causing more of or relating to more of a contractility stage of the uterus, and progesterone's more of a quieting hormone. That's kind of how I remember it when I was learning to teach this class. In the beginning of the pregnancy, we don't want that uterus to be contracting. So the estrogen's low, the progesterone's higher. And as we get towards the end of our pregnancy, we want to have contractions. We can have our baby. So our estrogen levels go up, and our progesterone goes down, so we can have those contractions and then go into labor. And prostaglandins, we talked about prostaglandins a lot in our high risk lecture, right? When we talked about the cerclage placement, and specifically I'm going to talk about that because I talk about prostaglandins there. Whenever you manipulate the cervix, especially when you're doing surgery on the cervix, but even when you're doing lots of vaginal exams, anytime you manipulate that cervix, prostaglandins are released more. And prostaglandins can cause irritability in the uterus, can cause some contractions there too. So those are these 4 hormones we talk about a lot when we're together because they're really important depending on the gestational age of our pregnancy. And then over here, specifically talks about the skin changes, okay? So chloasma is this box here. It's an increased pigmentation of the face. Not everybody gets these things, right? But if your patient says, I have, some people call it looks like a butterfly wings. If you can kind of see, they go like here. All right. That's just because of the pregnancy hormones, and that goes away. And then this is over here is called a linea nigra, which is here. It can the patients have a dark line that goes on their uterus. A linea nigra is more common in darker skin patients. Okay. And again, it all because of the hormones, and it all fades. So kind of following up on our conversation, which we had just a bit ago, before we round out this piece of our content here, and I'm going to say it again, the more your patient trusts you, the more information you're going to get from them, which will allow you to be the best nurse you can be. In our world, we ask a lot of very private questions where other nurses and other departments may not ask, maybe. And that's just because I need that to do my job. So we're going to go ahead and ask all of these questions. What's their plan to prevent a pregnancy after they deliver? Do they want to take medication? Do they want any kind of contraceptive help? Maybe they were taking contraceptives before they got pregnant and they're concerned about that. Have they had anything untoward in their gynecological journey? Have they had abnormal pap smears? Do they have any STIs? Have they been pregnant before? Have they had miscarriages? Have they had abortions? If they have had babies before, what was that pregnancy like? What was the labor like? Any complications of either? I want to know everything. The more you can tell me, the better care I can provide to you. Any pre-existing conditions, any surgical history at all, anything. Tell me everything. But remember, your patient may not voluntarily give this information to you. You're going to have to ask these questions. Now, some patients might just tell you everything, and that's always really lovely when that happens. But most people are private, and that's totally fine. So again, you're going to have to ask these questions. What's their diet like? They're growing another person. Do they eat lots of fast food? Do they live in a place where they don't have access to grocery stores? Do they only get their groceries from what are they called? Like a 7-Elevens, those, because they don't have a grocery store close by where they live. All of these questions. And we're going to talk about social determinants of health and all of this stuff in a bit, but this is all really important because this person is growing another human being. All right, let's move into the second piece of our conversation here today. And we're going to prepare for the pregnancy, preparing for childbirth, and how we can have the best outcomes possible. A couple overarching conversations here. Again, I keep saying it, we're growing a person here. So anything that we put in our bodies, if we're the patient, goes directly to the baby that we're growing. So we got to make sure that it's safe. We need to make sure that everything we put in our body has been cleared by our healthcare provider, over-the-counter medications, supplements, anything else. Talk to your healthcare provider before our patients start taking them. No alcohol and no smoking. No drug use, clearly. Now, that doesn't mean your patient's not going to do that, but you got to make sure you ask that. Any drinking or smoking or recreational drug use during the pregnancy. And that's how you say it, because that doesn't have any bias or judgment. It's just a statement, okay? Excuse me. Ideally, when you're pregnant, if you're a person who is very active, you go to the gym, you don't need to, unless you have a high risk pregnancy, right? But if you have a low risk pregnancy, you don't have to stop doing those things. You would just talk to your healthcare provider and let them know what your regime was or your routine was before you got pregnant. And there's a really good chance they're going to have you keep doing that. However, if you live a more sedentary lifestyle, the recommendation is not to start something new in pregnancy. So it depends on where they're starting from. But either way, it's important that your patient who's pregnant gets at least a little bit of exercise a day. If nothing else, walking around the block, getting some movement in is really good. No hot tubs, no saunas, drink enough water, and make sure our vaccines are up to date. This is a very busy slide, and for that, I apologize to you. What this is. So these are categories A, B, C, D, and X. So these are categories that were developed by the Food and Drug Administration, which is the FDA, that let people know what's safe to take in pregnancy. Now, my caveat here is that there's not many things that are totally safe because, again, we're growing a person. The conversation needs to be, now, does the benefit outweigh the risk? That's really what the conversation's going to be like, okay? Before we look into that, the first trimester, because of the teratogens, right? We've talked about how important the first trimester is for fetal development, especially in the first 8 weeks. That's when all these organs, these big, important organs, are developing. So ideally, we don't take anything in the first trimester because that's the biggest risk for the teratogenic effect to happen. And again, we've talked about that. And maybe there's alternatives that our patients can use. So it's important that we discuss those too, as long as they're in a professional setting with our healthcare team, okay? All right, so what I did here, I went through each category and I tried to give you examples so you make it more relatable. It's not just words here. So category A means that it's 100% safe. There's no risk at all. There's a very, very, very teeny tiny list of things that fall into category A, just saying. Category B, we did some testing on some animals. It doesn't show any risk to animals, but there's not been any tests done on pregnant people. Okay, so that's what that is. Penicillin is an example of that. Category C means that no one's tested anything. No testing on animals, no testing on humans, okay? And these are medications. This is an example of category C. Category D means that the evidence of human fetal risk exists, but the benefits outweigh the risks. So there's things that you have to keep taking when you're pregnant. They have done some studies and they have found that, yes, it's risky, but the benefits of taking the medications outweigh the risk. Again, the discussion needs to have between the patient and the healthcare team. Category X means that the fetal risks outweigh any positive effect. All right, so don't take a category X medication. So we teach about a lot to our patients that are pregnant, okay? And I would stand to say that the healthcare team provides teaching to the patient and their families about all of these things. All right? It shouldn't just say nurses. I'm actually going to cross that out and I'm going to say the healthcare team. I like that better. Healthcare team. So we, as a group, provide teaching to our pregnant patients and their families about all of these things. That way they can make a decision, an informed decision about the care that they want to have and about the labor that they want to have. All right, in your first trimester, people are tired. Like I already said, you're tired. You're the most tired in the first and the third trimester. Your second trimester, you're feeling pretty good. All right. So how I wrote this information here is, and I have a whole slide, by the way, and I think it's like in 3 more slides here, that talks about the most common discomforts in pregnancy and how to find relief. So you'll see it'll say, I don't know, nausea and vomiting and what you can do about it. So you can put a pin in that until we get to that slide. In the first trimester, we need to talk about lifestyle. We need to talk about exercise, nutrition, sexual health. People are uncomfortable to ask questions about sex. It's a very private conversation, so it's important for the healthcare team to be comfortable talking about it, knowing that your patient may not ask but certainly may have questions. The most common question I have heard is that, is it safe to have sex in pregnancy? And my answer is yes, as long as you are a low risk pregnancy. Semen has prostaglandins in it. Semen can, and if your patient's having sex with a man and there's semen, right, there's prostaglandins in there, and it can cause a little bit of irritability in the uterus. Now, if somebody's a low risk pregnancy, that's not as big of a deal. But if you have a high risk pregnancy, we don't want that uterus to be irritable. We want it to be really quiet. So again, that's my biggest question that I get from my patients. When complications to report, we talked about this with the antepartum high risk, which was as of right now in week 4. Fetal growth and development. Were they planning for the pregnancy? Were they not? Is this a surprise pregnancy? Do they have the resources that they need to have a healthy pregnancy? Okay. The lab test that we're going to do and things to report. I want to pause and say here, remind your patients and find a delicate way to do this, but this again this transcends over any kind of nursing. Many people get their information from the internet, good or bad. And we need to make sure that our patients understand that anybody can write anything on the internet. You don't have to have any kind of schooling. You don't have to have any kind of training. And so we want to teach our patients how to be smart consumers of the internet. And if they're going to get information about their health care, which many people do, what websites are the best? What websites are not the most reputable? Okay, so they can at least have accurate information. All right, second and third trimester expectations. Let's do second first. All right, so as you get in the second trimester, you're starting to feel a little better. You're not so tired. All right, you might maybe not really showing in the pregnancy yet, but you're starting to feel fetal movements, and that's very exciting. You know, all these kind of fun things start happening in the second trimester. Your patient might start thinking about, are they breastfeeding their baby, or are they going to bottle feed their baby? What are they going to do if they have to work? You know, having all of these thoughts on how we're going to support this human once it's born. Again, what's the most common discomfort of the trimester they're in, and how to help them with that? And there's a whole slide for that. Fetal movements, we already talked about that. Do they want they might be having thoughts about what kind of labor they want to have. I will say everybody has a birth plan. Whether your patient comes in with a printed, pre-written birth plan or just an idea in their head that they want, everybody has a birth plan. So I encourage you, if you have the time, if your patient's coming in and they're 10 centimeters dilated, it's a little bit different. But if you have the time, spend a bit and figure out what their birth plan is and how you can help them achieve what they want. Now, the caveat to that is that a patient can have the most elaborate birth plan, but if the baby is not stable, if we cannot establish fetal well-being, most of your healthcare providers are not going to follow the birth plan, because fetal well-being is everything, and patient well-being, right? So we got to make sure. So you always want to tell your patient, you know, we can honor your birth plan, especially the healthcare, the delivering person, whether it's a doctor or a midwife or whoever, will probably want to look at the birth plan and have a conversation with your patient about their idea for their birth plan. And you might hear them say, we can do that, or we can't. And if we can do that, as long as the baby is doing okay. Or if a healthcare team provider cannot honor the wishes of the patient, It is best practice, instead of just saying I'm not doing that, to give them the reasons why we can't do it. And have a conversation with them. Okay, again, meet them where they are, and how we can have this baby as a team together. Lifestyle concerns in your second trimester. Sex and pregnancy, I already kind of talked about that. Okay. Rest and relaxation, seatbelt safety. As this uterus gets bigger, and you know it gets bigger, right? The lap belts on the seatbelts, we don't want the lap belt to go directly across the middle of the uterus. So what you want to tell your patients is to take the lap belt and tuck it under the uterus, almost on top of the hip bones, covering the bladder. So that way, think about it. If you're involved in an accident and the lap belt is cutting across the middle of your uterus, and the driver stops short, the lap belt's going to dig right into the uterus muscle. Okay, so it might cause complications like preterm labor, an abruption maybe. So the evidence and research says to have the lap belt over the hips, low, under that uterus. So if the car does stop fast, it's not digging into the uterus. That makes sense, right? We already talked about posture. If your patient's going to travel, it's important that they speak to their healthcare provider. The healthcare provider can't tell them, no, you can't travel. I mean, I guess they could, but it's up to the patient to do it. They're going to do whatever they want. It is not uncommon to have healthcare providers encourage the patients to bring a copy of their prenatal record with them if they have to travel. And I think that you would understand why. I mean, if somebody's having complications of pregnancy and they're in a different state where their healthcare provider is, they're going to be directed to go to the hospital closest to them and be seen there. But if they have their prenatal record, all of their doctor visits or their healthcare provider visits from the time that they got pregnant up until the last time they were seen are on this document. All you have to do is give a copy to the hospital that you're at, and then they can be seen there. That way they have the history of your patient. So that's really the best practice to do. Complications of pregnancy, I covered all of this in our antepartum high risk lecture, so we don't have to go over it again. But again, if you're a little rusty, revisit that. We talked about a birth plan, talked about renewed energy, so we can move on to our third trimester. So now we're getting really, getting closer to having our baby here. The person really should be thinking about what is their plan for labor. If they're having a scheduled C-section, what's your plan for that, right? So what's their plan? If they're not having a scheduled C-section, if their idea is to go into labor, what's their plan for pain management? I will tell you, there are lots of people who are surprised that labor hurts as bad as it does. There's lots of ways to combat that. You can go to childbirth education classes. You can go, and at those classes, they will teach you different breathing and relaxation techniques that may help when somebody is in labor. Effleurage is one way that we can relax, and that's just light touch. Light touch is very soothing to lots of people. Not everybody, so it's important to know where that your patient or yourself, if you're the patient, is at with that. But all effleurage is you're going to take, the tips of your fingers and drag them over like in a butterfly pattern over the gravid uterus, just side and around. That really is very relaxing. Okay, that can help relax somebody. Counter pressure is if their back is sore. You go back to the slide where I showed you, where as you get closer to in your third trimester, your back, you have that curvature of the back, and that's really uncomfortable. It might help to have counter pressure. You can have them like leaning on a tennis ball maybe, or if they have a partner who's willing to participate, have them just using the heel of their hand. Not really rubbing per se, if they want it that way, but certainly the pressure can help with the back. Sometimes heat or ice packs can help, okay? TENS units can help with that. So, figuring out what works for them. Once they're in labor, it's really, really important to involve the people who are going to be in the patient's room when they're in labor. An example of that for you to think about is if your patient has decided that they want an epidural in labor, and their partners, they're not going to stand in their way, but their mom or somebody else, their aunt, somebody else who is their support person doesn't want them to have their method of choice for pain management. How would you handle that? When your job is to advocate for the patient. So in the best case scenarios, and the counseling should be from the person who's seeing the patient at this time, is to involve people who are, let the people who are going to be in the patient's room know what their plan for labor is for pain. That way, if they don't like it, they can deal with it before the person's in labor. Okay? Let's talk about this little bullet right here. The labor process. The labor process is different depending on the number of babies that the patient has had. And again, this is review. We've talked about the labor process for weeks now. You already know that when somebody's having their first baby, it takes longer. The bones are tighter, the muscles are tighter. And the more kids you have, the more kind of loosey and stretched out things are, and the faster it is. That's what that sentence means there. Some of you might not know what a doula is, so I'm going to tell you what a doula is. A doula is a support person for labor. They can be licensed, they can be unlicensed. It just kind of depends. I do know you don't have to have any special licensing to be a doula. You take some classes and get certified as a doula, but it isn't required. I don't believe in many states anyway. I could be wrong, but you don't really have to have licensing to be a doula at this point right now. So what the doula is you can have a doula, a pregnancy doula, a labor doula, a postpartum doula. It's a support person for the new parents is really what that person's job is. They help focus them. Let's talk about a doula. That's how we use a doula in labor. They come in with they at least some hospitals might provide them, but I don't know that many of them do. Oftentimes it's a private agreement between the patient and the doula. When the patient comes into the hospital, the doula comes with them and they would help them breathe with contractions and they massage their legs and they're kind of that support person there. The nurse is different, right? The nurse is in charge of the well-being of the patient, the well-being of the baby. The doula is really focused on the patient and supporting their breathing and those kinds of things, okay? That's kind of the role of the doula there. Letting them know that this is normal stuff, okay? So what can they expect? What's normal? Leg cramps, hemorrhoids, back pain, everything's getting heavy. Fetal kick counts can start happening in the third trimester, and babies, and your book right now says 3 in an hour. Now you may meet some healthcare providers that say, no, I want them babies to move 6 in an hour. So there might be some discrepancy on the amount that is told to the patient. But basically the teaching is the same, even though that number might change. The patients are going to be told, lay down on your side for an hour and monitor the baby's movements. It can be a flutter, it can be any movement at all, and it needs to equal this many movements in an hour. If you don't have that many movements, they'll probably be instructed to call the healthcare provider or to go to the hospital to be evaluated. That's what fetal kick counts are. You know what testing for fetal well-being is. That's already been covered. I already talked to you about how the patients are getting more tired now. And we want to talk about what's their plan, breastfeeding, bottle feeding, or both. Or do they have to work outside the home? And maybe start thinking about how they're going to support, if they plan to breastfeed, what are they going to do when they go back to work? Do they have a place that they can pump? And all those kinds of conversations. Again, another busy slide. My apologies here. But a bit about iron deficiency anemia. So it is the most common medical complication in pregnancy. Right here, this really kind of talks about the iron needs on somebody who is pregnant and where kind of the iron goes to. How much goes to the fetus, how much goes to the blood volume, and how much goes into the placenta. Okay, so that's just in case you were curious for that. Somebody who is anemic, all right, these are the risks of somebody who's anemic. Everything is pretty self-explanatory, except for most of the students, they don't know what this word means. How you pronounce that is pica. Pica is cravings of chewing things because you're anemic. The textbooks say patients will sometimes crave eating clay and dirt. I will say in my experience, oftentimes they like to chew ice. And it's just a constant chewing of ice. So if your patient comes to you and says, I'm really tired and I've been eating lots of ice, somebody should be checking their hemoglobin, okay? Some risks to the fetus: low birth weight, prematurity. I'm going to write that because it got cut off. and stillbirth. So having enough hemoglobin in our system is really important. The problem is that if we cannot get enough in our diet to bring up our hemoglobin in our pregnancy, we have to take supplements. And there's a really big problem with compliance with taking iron supplements because they're horribly constipating. And being pregnant is already constipating because it moves all of your organs out of the way. So you need to talk to your patients if you're going to ask them to start taking iron in pregnancy, and to encourage them and tell them why it's so important. It's important that we want to take vitamin C with our iron because it really helps with the absorption. All right, so our second and third second and third trimester dangerous signs. And again, this is something we've already covered in our time together. So this is all going to be review for you. And here is the slide that I've been talking about. The common discomforts in pregnancy and what you can do about it. I'm not reading this to you. It's just, you guys can read it, right? But it's, even though I know it's busy and I apologize, but my goal here was to have it on one place. You guys can look at it and see your patient is experiencing this. This will happen in this trimester, is what you can do about it. So that's the intent behind this slide here. So our next two slides talk about nutrition and pregnancy with the overarching theme that this person is now responsible for growing another person. So we have to talk about nutrition, right? It's a big part of it. It promotes fetal and maternal health. Here we talk about the recommended weight gain in pregnancy. So our first trimester, there really shouldn't be very much weight gain, a pound to about 4.5 pounds. Your second and third trimesters are going to be about a pound a week. And that's going to be different if your patient's starting out in their pregnancy overweight or underweight. So there can be some some adjustments made on weight there, with the advised pregnancy weight gain to be between 25 and 35 pounds only, okay? Inadequate weight gain can lead to a baby that's too small, right? And which, again, makes sense. Folic acid's really important, as it helps with the fetal neurological development and preventions of fetal neural tube defects. It is recommended by the March of Dimes that people who are in childbearing age, okay, which is a lot of people, they should be taking 400 micrograms of folic acid every day. Now, once that person becomes pregnant, they need to up it to 600 micrograms. Calcium is important, okay? So we want to take at least 1,000 milligrams of calcium when we're pregnant and drink 8 to 10 glasses of water a day. All right, so here, and again, just trying to make it not so much information, but our calories need to go up depending on our trimester and if we're breastfeeding or not. Now, if after we deliver we're not breastfeeding, we don't have to keep eating calories to support breastfeeding, right? So our second trimester calories go up, third trimester goes up, and again, this should make sense to you. This baby's getting bigger. It's taking more from its parent. It's taking more and more and more. So we need to eat more so the baby can take more away. All right. Increase our take of protein, increase our folic acid, supplements if we need them. If not, a diet that's high in iron is good. All right. And we're limiting caffeine as well. All right. So now we're going to talk about access. We're going to talk about things that affect our patients, and our population here, of course, are pregnant people or people that are trying to get pregnant. So that's what we're going to focus on just for the next little bit, okay? So I first want to introduce something. This might be new to you guys and maybe not. That's fine too. Something called the social determinants of health and equity, okay? So this is according to Healthy People 2030. This is where you'll see I'm very clear with you guys on where I get my references, especially in this section of the class, okay? So the social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect the range of health functioning and quality of life and outcomes and risks, okay? It is grouped into 5 domains. So there's 5 domains of social determinants of health. They are, and this is what this picture is here, by the way. They are economic stability. And here we're talking about jobs. Can they afford food? Okay. Number 2, education, early childhood education, literacy, language, which we're talking about there. Number 3, social and community context, discrimination, incarceration. Number 4, health and healthcare. Here we're talking about access. Are they aware of their rights? What do they know about the healthcare system? Do they know how to access the healthcare system? And finally, the neighborhood that they live in. Do they have access to healthy foods? Do they have access to grocery stores that have produce departments so they can access the fruits and vegetables that they need? Are they experiencing housing insecurities? Do they live in an area where there's a high crime rate? That all falls under the neighborhood here. People who don't have access to grocery stores with healthy foods are less likely to have good nutrition, which leads to a greater risk of health conditions, which makes sense, right, you guys? You don't have access to eat the right things, even though you know you're supposed to. You either don't have them or you don't have the money to buy them, and so it can kind of gets very is that there's the intersection there of all of these things that can lead to a greater risk of health conditions. So here, as we're talking about social determinants of health and equity here, we're going to talk about race and racism as we start talking more about implicit bias and having those conversations in just a minute. So this slide honestly is just a list of definitions for you in case you didn't know, or if you did already know, then it's just kind of a more refamiliarization of what racism is, okay? And then the structural racism, cultural racism, and discrimination makes you understand. We're going to talk about implicit bias in just a little bit here, because there's lots and lots of conversation that talks about implicit bias and how we have poor outcomes related to this with our patients, and then discrimination and microaggressions. All right, so now let's talk about cultural and societal issues in childbearing, okay? Overall, there are quite a few maternal deaths a year, and there's probably more recent. This is the last time I looked, is where I got that from. All right. Maternal mortality rates doubles for every race and ethnicity in the past 2 decades. And this right here is a list of the pregnancy-related deaths that occur within 1 year of pregnancy. So just kind of knowing that there too. 84% of pregnancy-related deaths are preventable. We all know that all of us going through the COVID-19 pandemic, and especially those of us in healthcare, but all of the people that did, are aware that the pandemic exacerbated the healthcare disparities that our patients are experiencing, okay? For people of color, including huge disparities in maternal and infant health as well. With the overturning of Roe versus Wade, there's increased barriers to abortion for people of color, and it may widen the already existing large disparities in maternal and infant health. Due to social and economic factors, structural and systemic racism and discrimination, as well as the intersection of race and gender and poverty. So this is explaining why there's the increase and the issues with maternal and fetal deaths. And Black American Indian, and Alaska Native individuals have higher rates of pregnancy-related deaths compared to white individuals. So this slide basically are statistics and what the research says why the numbers are the way they are. So overarching, Black people experience more than double rate of maternal deaths from pregnancy-related causes than white people, and triple the rate compared to the Hispanic individuals, all right? And that overarchingly is because of access to quality health care, underlying chronic conditions, and structural racism and implicit bias. We're going to talk about implicit bias in just a few slides here, okay? These individuals experience higher rates of some preventable diseases and chronic health conditions, all right? And these conditions and diseases directly impacts pregnancy, and it can have a negative impact on fetal outcomes and pregnancy outcomes as well. They experience greater health disparities related to the intersectionality of race, gender, age, and other socioeconomic factors, like healthcare insurance. Okay? According to research, Black women report feeling dismissed, overlooked, and ignored by their healthcare providers, being talked down to by their healthcare providers, and they also experience mistrust of the healthcare system due to institutional racism and a history of reproductive oppression and discrimination. This is just a visual for you of the pregnancy-related mortality by race and ethnicity, and from 2016 to 2018. So it's a little bit dated, but you know, you have to have some history to get dated. So this is more of a snapshot from a few years ago. So the numbers may have changed more currently. So next, we're going to talk about another group of individuals that can experience in healthcare disparities. Our queer population, our LGBTQ plus population, okay? And I just have statistics here. This just tells you what you can expect for the clients that you're serving. 11.2 millennials, and that tells you what the age is here, and 19.7 of Generation Z. Here's your age group here. Identifies lesbian, gay, bisexual, or transgender, okay? Heteronormativity is common in hospital settings. What I mean by that is instead of asking somebody who is a female in front of you when their husband's going to be there, that's heteronormativity, is the assumption. What you want to ask, you can ask something like instead is, when is your family coming? That may help decrease that there. There's a risk of postpartum depression, and it gets to be higher in this community. Pregnancy is most often focused on women, but not all people who are pregnant identify as women. So that can be a conversation issue there. LGBTQ populations have significant health disparities, particularly if they are from a racial or ethnic group or have a disability. And there's that intersection I keep talking about. The more intersections you can have the greatest impacts on their health care. Okay. They experience mistrust of the healthcare system because of discrimination, and these are some of the barriers that can be experienced by this population. Regardless of gender or identity, prenatal care is essential for all pregnant people. All right. So, what can we do as nurses to really support this population? All right, and that's kind of how I listed here for you guys there. And I included this statement from the March of Dimes that I just found. I just thought it was very powerful. We believe that all parents and babies, regardless of race, ethnicity, culture, language, or national origin, poverty or socioeconomic status, gender identity or sexual orientation, disability, region, or place, must have an opportunity for optimal maternal and birth outcomes. And that's from the March of Dimes. Now we can talk about people experiencing homelessness. This is a situation that many of us come in contact with as nurses and just people that live on the planet right now. When we're talking about people who are having babies and they're homeless, that presents other problems because now we have a newborn who is also homeless as well. Individuals need stable housing to be healthy. Housing instability is almost always accompanied by low incomes. Pregnancy can increase a person's risk of becoming unhoused. Homelessness and unstable housing during pregnancy are associated with low birth weight and preterm delivery. People with limited resources and unstable housing are exposed to a number of health risks and often cannot move to another neighborhood. And people experiencing homelessness have a higher risk of things like HIV, drug use, mental illness. Providing stable housing along with social services improves mental and physical health in individuals. Again, just some data that I found. We should probably have a conversation about food insecurities because our patients are growing humans now. Okay, so food insecurity may increase the release of stress hormones, and that can lead to preterm delivery. So that's a problem. We don't want people to deliver preterm. It disproportionately affects Black, Indigenous, and women of color. It's defined as households without resources to purchase adequate food to maintain an individual's health. People residing in low-income neighborhoods have less access to healthy food options and an overconcentration of fast food and convenience stores. Without adequate nutrition, fetal growth and development cannot proceed normally. Food insecurity is associated with birth defects, anemia, cognitive problems, and poor general health. And we all know that the COVID-19 pandemic has exacerbated food insecurities. All right, finishing this out, we're going to talk about implicit bias, okay? So implicit bias, by definition, refers to the positive or negative attitudes or stereotypes activated automatically and involuntarily that affect our understanding, our decisions, and our behaviors without our awareness or voluntarily control. There's a lot of evidence that talks about healthcare outcomes and disparities related to implicit bias. Implicit bias significantly affects how healthcare professionals perceive and make treatment decisions, ultimately resulting in disparities in healthcare outcomes. All right, so it's important that we as nurses, certainly all of the healthcare team, but certainly as nurses, be aware of our own implicit bias and be aware that we have it and that it's affecting the care that we're giving to our patients. Healthcare disparities are often considered to be racial or ethnic issue, but people are subject to unconscious bias based on many factors including sex, sexual identity, socioeconomic status, educational level, age, disability, and geographic location. So why does it matter? Why does implicit bias matter? It matters because it can negatively affect our patient outcomes and worsen healthcare disparities. There is tons of research that says and supports this statement, and that says we as human beings and nurses need to be aware of our own implicit biases so our patients don't have negative outcomes. I want to talk to you a little bit about the Assembly Bill 1407, and because it directly affects us as nurses. It's called implicit bias training. There's a bill that requires implicit bias training in nursing schools, and that also requires it to have new grads need to be a part of it, and hospitals now have to have it as part of their annual training as well. All right, so this bill requires approved schools of nursing to include participation in implicit bias training for students. Requires individuals with an RN license to submit proof of training within a 2-year period. Requires hospitals to implement implicit bias training to their new grad programs. And I should have put bullets here, but implicit bias training is going to include all of these. The government said that the healthcare outcomes that come because of implicit bias are so negative that we need to have training so we can provide better care to our patients. That's pretty much what that is. I'm not going to cover all of these. I have one slide that covers reproductive justice, and then we can be done with this conversation. So we already talked about this bill, right? We talked about Assembly Bill 1407. That's because we're talking about implicit bias. The last bullet on the training that needs to be included with implicit bias training is information on reproductive justice. So I'm going to give that to you now, okay, as required by the state of California. What is reproductive justice? Reproductive justice is the right of people with the capacity for pregnancy to have access to reproductive health, including the right not to be pregnant in the form of birth control or abortion. There is a framework, reproductive framework, and that here's you can see where all of my references come from. But the framework for reproductive justice is basically what it says here. What are our rights as people? We have the right to decide when and if an individual will have a baby and the conditions under which they will give birth. The right to decide if they will have a baby and their options for preventing or ending a pregnancy. The right to parent the child they already have with the necessary social supports and healthy community without fear or the government, the right to raise children, the right to plan their pregnancy, the right to terminate pregnancies, and the right to express sexuality. That's what reproductive justice is. So we've talked about social determinants of health. We've talked about a few of our groups who have a history of healthcare discrimination. Okay, just a few. We've talked about a couple of them, and we talked about implicit bias and what that means to us as nurses and why it's important. We've talked about reproductive justice because I wanted to teach you what that was. So it's a lot. Maybe this is all new to you. It's new to a lot of us, and that's okay. It's important that we understand, I think, overarching what it is and why it matters. It's important that we address all forms of racism so our patients can have the best healthcare outcomes as possible. It's important for us as nurses to advocate for policies and laws that promote equity and the delivery of high quality care to all individuals. It's important that we, as humans, understand our own biases and how they affect other people, that we advocate for the rights of patients, that we understand what social determinants of health is and what it means and why it matters, and that we expand our roles to care, partnering with communities and other sectors of healthcare to all have the same goal, to have positive healthcare outcomes.